Professor Ahmed Kaseb from MD Anderson, and his topic will be not far away from the first one, but it will be more insight, I think, about the novel IGF score to risk stratify patients with HCC. And after he finishes his talk, I will ask the three speakers to come up at the panel here, and if there are any questions. Dr. Kaseb.
Thanks again, Dr. Mahmoud. So I know it's a long day, so we'll be very brief here. And we're all very familiar with the Child-Pugh classification for hepatocellular carcinoma. So this was a trial from our end that started about 4 years ago to challenge the standard of care system, which is the Child-Pugh in stratification of hepatocellular carcinoma patients. So I have no disclosures. We'll take a very quick snapshot at the Child-Pugh score and then discuss the development and the validation of the modified score, and then future outlook of this scoring system and conclude. So all depending on this hallmark that most of the patients have underlying cirrhosis, and the only score to assess their liver status is the Child-Pugh classification. So the original score was actually introduced in 1964 and then was modified in 1973 by replacing the most subjective variable, which was nutritional status originally, with prothrombin time. So was actually developed, and most of us know this, to assess the life expectancy in the setting of transection of the esophagus for portal hypertension associated with variceal bleeding. And then eventually became the standard tool to assess the hepatic reserve and predict survival in cirrhotics. And since most of the HCC patients have cirrhosis, it also became the standard tool to assess the underlying liver status in HCC patients. So we're all very familiar with that. It has 5 variables. Encephalopathy and ascites are the clinical ones. And as we just mentioned, was developed in 1973, so there was no scans, CTs or MRI, were all dependent on the clinical assessment of those variables. So you can only see how hard it is to grade anybody clinically with ascites and encephalopathy, especially with treatment. These things change. So this week they may have large ascites, and next week they have no ascites because of diuretics or other factors. Same thing with encephalopathy. So they vary with treatment as well. So since survival rates are very low universally for Child-Pugh B and C, the standard approach is to treat patients with Child-Pugh A aggressively. So patients who are candidates for local therapy or surgery or even sorafenib, all of them had to have Child-Pugh A. Actually, the SHARP study that approved sorafenib, one of the inclusion criteria was Child-Pugh A only. And also all the following phase 3 studies for HCC included Child-Pugh A only for this purpose. So, and this is adopted by the most of the national, international guidelines, as we all know. So to sum it up, it's primarily used to predict survival and response to therapy, and to guide therapy decisions and stratify patients under staging systems. So what are the challenges? So one of them is the outcome can vary among patients within the same stage. We all know this. We all have treated patients with Child-Pugh A, and some of them fail right after the treatment, whether this is systemic therapy or local or even surgery. Also, as we discussed, it's partially based on subjective assessment of empiric and dynamic clinical parameters, encephalopathy and ascites. So, and as we said, it's integrated in all the classification systems. Based on the fact that we're not getting biopsies as much as we used to for HCC, it is critical to look for something that is non-invasive based on the blood to assess the liver reserve. So, and we discussed the fact that we have 2 main categories for non-surgical cases based on BCLC and Child-Pugh classification. So So we looked into the insulin-like growth factor, which is mainly synthesized in the liver. So most of the circulating, the blood IGF-1 is synthesized in the liver. So it decreases sharply in cirrhotics, any chronic liver disease. A lot of studies looked into that, including patients with hepatocellular carcinoma. It also correlates with the liver reserve, grade of fibrosis, different scores such as the Child-Pugh and also MELD score. We looked into that in a few studies looking into IGF association with overall survival, tumor parameters, because the tumor would act as a space-occupying lesion that decreases the hepatic reserve. So now let's look at our studies. So the hypothesis was that the plasma IGF-1 can be substituted for the subjective variables within Child-Pugh classification to create a novel objective liver score to increase the prognostic accuracy. So we started with a training cohort. Retrospectively, we assessed IGF-1 in 310 patients and compared the new score to the old score. And then we prospectively enrolled 155 patients and assessed IGF and compared the results in both scores. That was based on NIH funding in the United States. So patients were accrued, the validation cohort was accrued in the last 2 years. The retrospective data were from stored samples of patients. And then we did recursive partitioning, which is a statistical method to identify ranges of any marker that correlates with survival. So based on our analysis, patients had 3 distinct groups, more than 50 IGF-1 level in plasma between 26 to 50 and less than 26. This was actually also correlating with the literature. If you look into literature from the liver literature, IGF-1 in cirrhotics, for example, so you will see the level less than 26 correlating with Child-Pugh C, and 45 to 50 correlating with Child-Pugh B, and also with moderate fibrosis in the liver. So this was consistent with prior studies. And then we modified the score by eliminating ascites and encephalopathy and adding IGF-1, and used C-index and used statistics to compare the prognostic performance. So this is basically it. So now it's all blood-based, so no encephalopathy or ascites. You just assess albumin, PT, bilirubin, and IGF-1, which is a standardized test that is done in any clinic setting. The endocrinology teams use it a lot for growth hormone. So this is a standardized test that you can order anywhere. So this is the patient characteristic table. There was no significant differences in terms of tumor differentiation, age, gender, all of that. This is the first snapshot at the overall survival in both the training cohort of the 310 and then the validation cohort 155. So you see this is the Child-Pugh score, survival A, B versus C. So very consistent. And this is the new score IGF-1, also 3 groups. So let's now look at the distribution of patients according to the old versus new. So here, this is the old Child-Pugh A patients, and then this is the new score. So Child-Pugh A patients were divided into new A, new B, new C. This is the training cohort. And then you go to the validation cohort, the old Child-Pugh A is also subcategorized into new A, new B, new C. So you see how many patients are shifting from old A to new B and C. So it's here 28% in the training cohort, 47% in the validation cohort. And equally important, you see patients moving up. So patients moved down from old A to new B and C, and also patients moved up from old B to new A. So you can actually select those patients who are gonna do poorly from the Child-Pugh A, and you can select patients who are gonna do better than expected from the Child-Pugh B because they moved up to a new classification A. So this is also gonna help us a little bit get this point, which is basically depending on the overall survival analysis here, this is the patient's population of old A. So these patients are divided into new A, new B, new C. So you see patients who remained under A perform the overall survival is 15 months compared with 9, and then 2.3. Here is 25, 11, 1.2. So you see how heterogeneous is this patient population because they were all lumped under old A. So this is the original A patients moving to A, B, C, and then so on and so forth. You see also original B patients move to new A, new B, new C, and so on. So the group that I talked to you about, which is the original B, moving to new A, so you see their survival is much better than expected. And we've seen that in clinical practice. You see somebody with Child-Pugh B, but you do TACE or Y90 and they do much better than expected. Some of them, even without treatment, they live longer than expected. So this is another way of looking at it by the Kaplan-Meier curves. And this is again looking into Child-Pugh A only and see how difference is their survival based on the new score. So this is in the training and validation cohort. So you see patients new A, new B, new C, and this is all, remember, within the Child-Pugh class A only. So these are the patients who are candidates for active therapy, whether systemic, local, or surgery. So you see how they could be subcategorized based on the new score into 3 different prognostic groups. So this is the C-index analysis to compare the prognostic accuracy of both scores. So you see the C-index here significantly better in the new score as compared to the old one in both the training cohort and the validation cohort. And you might think these differences are slim, but if you look historically at the MELT score, was also based on the assessment of the C-index analysis between Child-Pugh and MELD. So you see the difference is also less than 0.1. So this is historically the one of the best prognostic comparison tools we use, the C-index analysis. So let's sum it up. So the IGF score significantly predicted survival was more accurate than Child-Pugh classification in all classes, replacing the clinical assessment of the ascites and encephalopathy with the quantitative, the IGF-1 in plasma improved the prediction of survival. Patients were reassigned, as we talked about, so moved up and down based on the IGF score. So what is the future outlook? Number one, we really need international validation. Yes, this score was developed and validated in 2 independent cohorts, 1 retrospective, 1 prospective, but we really need to have international validation of this score based on different demographics and risk factors. We need to start looking into integrating the IGF score into HCC staging systems to replace the Child-Pugh classification. Also to evaluate the ability of the IGF score in predicting response to therapy. So the Child-Pugh classification A was chosen for all clinical studies based on the fact that those patients generally do better with treatment. We don't know how the IGF score is going to work. Presumably it's going to be better in this aspect, but we have to prove this prospectively. So we need to internationally validate this score and also look into the ability of the score to predict response to therapy. So in conclusion, since HCC is a 2-disease state, Child-Pugh classification is the standard tool to assess the liver reserve, and despite the limitations we discussed, it remained the standard tool. So by elimination of those subjective parameters with IGF-1 and relying only on blood tests that could be done anywhere, we were able to better predict their survival. So it was more accurate, including a prospective cohort. And this was just published at the JNCI, so it's available. I also have a copy. If you couldn't have a copy online, you can just email me. So adopting it should improve the accuracy of predicting the hepatic reserve for HCC patients, could aid in stratification of patients in clinical trials and avoiding unnecessary harm of patients with poor hepatic reserve, where we can avoid their treatment. However, as we discussed, we need international validation and including, of course, Egyptian institutions, before we can standardize its use for this purpose. So this is our team, and I'd like to thank you so much for your time and attention.
Very interesting. Thank you very much, Ahmed Kaseb, and I think there is a lot to discuss about this. Don't know now or later, because can I ask Dr. Shakir and Olivier Boileau to join us, and Antonio Martinez on the panel and to start. We have about 5 minutes for discussions. If there are any questions from the floor.
Yes, I have a question, please.
Yes.
Professor Martinez, I have a question, please. From your talk, we can see that the radioembolization is the gold key for treatment of HCC. So my question is, when not to do radioembolization?
No, I don't think the message was not that radioembolization is the answer. I think that the message is that chemoembolization is maybe not as good as we think, and that there is room for other therapies in a selected group of patients. So we cannot do radioembolization whenever the liver function is deranged in the sense of having a bilirubin higher than 2 grams per deciliter. If you work in micromoles, if I work it correctly, it's 34 micromoles, I think. That's the upper limit of normal. Patients, that's the only real absolute contraindication. Patients with ascites and with low albumin, I mean, all those are just indicators of a poorly functioning liver, really. We can still treat them, but the only special care we need to take is, in the terms of when calculating the dosimetry, take that into account. There was only 15 minutes to talk about this, so I can talk for 2 days. So many things I didn't mention. We have to calculate the dose of radiation that we're going to administer to the patient. And this is based on, well, there are 2 ways of calculating the dose. Both are mathematical formulas, because medicine is a science, but it's not an exact science like mathematics. So I think it's okay to apply mathematics in medicine, but then we have always to use common sense and tailor that to each particular case. I'm not sure I've answered your question.
I know that it will be a very long discussion, but still there is a role for TACE.
I think TACE, I think there's room for TACE.
You told that you haven't done TACE since 1999.
I haven't. That's my personal opinion. I cannot prove it. What I know is that you achieve. There's no study published where you actually compare TACE versus embolization, other than the study by Malagari.
Yes.
So I think that's indicative. It's just another sign. The only evidence we have for TACE nowadays, there were, I think, 7 studies. I'm talking out of memory, done, in the old days, and only of 2 of those 7 studies proved that chemoembolization is superior to the control arm. And one of them is the study by Lowe in the east, on the Far East, and the other one is the study by Jobet in 2002. If you look at the patients included in the Jobet study, 50% of them today would be candidates for radiofrequency ablation. So I think that points out to the fact that the patients included, at least in the Jobet study, were easy patients, or patients that were that a priori were going to respond well to the treatment. And we are working today. Our practice is just based on that weak evidence.
So my last question: in cases of arterioportal shunting, we can do radioembolization or no role for radioembolization? Arterioportal shunting.
Yeah. Okay. What you must avoid at all cost is to have the spheres going outside the liver.
Yes.
If you can deal with the arterial portal shunting in such a way that the spheres will remain within the liver,
we can do it.
Then you can do it. But I wouldn't recommend it for a beginner.
By coiling, not portal.
No, it's more, it's
coiling?
no, but the trouble is using a coil. Depends on the type of shunt. Depends on the type of shunt of arterioportal shunting. Coils is being a surgeon, coil is the equivalent to a surgical ligature, okay? But in the liver, I've lost many coils in the liver, okay? I think that we all have. I mean, people that say that they haven't, they are lying. No, lose them because poor technique or when you learn, even when you know a lot, you lose coils. You know, it happens, yeah? If you drive a car, sooner or later you hit it against something, yeah? This is the same. So when you lose a coil in the liver, you can see that immediately, you know, the area that has been coiled or occluded by the coil repermeabilizes by collaterals. And that happens within seconds. So another advice for the junior radiologist, if you lose a coil in the liver, don't try to take it out. Just push it in. Nothing happens.
Very rapid question, very rapid answer for you, if possible. You mentioned in the indication that I agree for all of them, the portal vein malignant thrombus, the infiltrative tumors, everything. But what about the bilobar tumors?
Bilobar tumors can be treated as well. Yeah. You can actually tailor the treatment in such a way. There is a syndrome called radioembolization-induced liver disease. It's a syndrome caused by the radiation to the liver, and that happens when you get the dosing wrong. When you give too much radiation, the patients develop this syndrome. This syndrome, if it's going to appear, appears within 6 weeks of the treatment. So a way of having a safety net is treating the liver in 2 different sessions. On one session, you can do the right lobe, and in the following session, 6 weeks apart, the left lobe, yeah. So if there is any mistake that, you know, any disease that you will be able to detect it before doing the second treatment.
Thank you very much. My question will be a very rapid question to Olivier about resection. If we do a liver resection and the pathology of the specimen showed high risk of recurrence like vascular invasion or high degree or moderate degree of differentiation, would you go immediately for transplant without waiting for recurrence, or would you wait for the recurrence when it happened?
It depends on the biology of the tumor, and what would you do if, in case of microvascular invasion, do you...
I mean, you did already resection, and the pathologists say this pathology. Yes. There are 2 points of views. One will say, wait for the recurrence and then transplant. One say, no, we know that it will happen, so transplant even before.
Okay, it depends on the centers, but I would say if, for example, there are poor differentiated tumor, only one tumor in the liver which you removed, and I will go rapidly to liver transplantation in this case.
Without recurrence?
Yes. Otherwise, if the tumor is well differentiated, wait and see.
What do you think of this, Ahmed? As an indication for a salvage transplant, would you wait for the recurrence, or would you go immediately with this difficult pathology or this dangerous pathology after resection?
From the medical oncology standpoint, these are the patients who could be good candidates for adjuvant, studies, and there is already ongoing some trials. Of course, we all know the STORM study is negative, so no one is using sorafenib for this patient population. But at our institution, we for those very high-risk patients, we try to do adjuvant chemotherapy for them, because most of the time they have excellent liver condition, and we try to do it in a selective manner. The PF regimen that I talked about, the same neoadjuvant, we use it adjuvantly. But definitely, I think as you said, the salvage, this needs to be studied more. All the data
never have a clear answer for this.
It's retrospective, so I think this could be a good one for you guys, for the surgeons to explore and let us know.
Okay. Hisham is waving to me to wrap and finish up. I will do this in a second, but I cannot do this without asking Ahmed Kaseb the last question in very rapid answer. So what we are proposing with the IGF score, do we list our patient for transplantation based on the IGF-4 and forget about starting from the B to, we usually list for liver transplantation when they are B8 or B9, we start to list patients. So did we reach the point to say that the IGF could replace the CTP or not yet?
No, so I think we need to have international validation first. So this was true for our patient population in the US, single institution, even though it's 2 cohorts. But unless we prove that the same score with the same cutoff points and everything is valid for Egyptian patients, we should not use it here yet. So I think the first validation study should come out from Egypt, because most of you guys, yes, so most of you guys have already some plasma samples saved, and this is all you need, because you don't need to do any other assessment. You just do the 4 tests, all related to the plasma or serum, and then you can get the answer right away. So since the score has been already validated in our patient population, you can rely on this to test it directly in your reservoir. So if you do this and show that it has the same kind of findings, then the next step would be for both of us to do a prospective study. So this prospective study, and we're actually started one at Anderson, is to bring all patients in as child-PU A, and then you treat them either with systemic only or local therapy only. So you treat them the same way, and then at the end of the study, you retrospectively analyze. So all of them were A. So did the outcome and the survival was different in those who are categorized now under new A, new B, new C. So this is the next step. So the first step is to do retrospective of your available samples, and the next step, and we could do this jointly, is to study the predictive ability of this score for patients who are undergoing either local therapy or systemic. Our surgeons also are thinking to look into that pre-surgical. So you also do the score pre-surgical and then look into the outcome based on it.
It's very interesting, and we need many hours to discuss this. I would like to conclude this session because we're already late, and would like to thank all of the speakers and my co-chairs, and for you at the floor for staying so late. And we still have work to do, or we got time to go to the dinner? So we will move directly to the next session. Yes, boss.